Well, I am presenting some very simple cases, not any complicated one meant for a younger age group of persons and not for persons like Vijay Raghavan and Anirudh Dey or so. Now, the first case, what I call is a corporate hospital syndrome. This was a 44-year-old lady who was admitted with an atypical chest pain. Now, why I'm showing this, I'll just let you know. And before anything could be done, they jumped onto a coronary angiography, and the angiography was normal. So she was being discharged as a case of a atypical chest pain with a normal coronary angio. Then they suddenly remembered that on the day of discharge, that her echo has not been done. And then they did an echo, and what we found out, this I'm putting just for the our this other younger PGs or so. So what we found was something this why I presented this case, that we have got a number of such cases, but we never had such a good Doppler recording what we did now. So this was the reason also for presenting this as a short case. So here what we found, that what is typically known as the lobster claw hand defect. This is like a lobster's claw hand. This is a inverted one, and then you invert it, it looks like this. This is usually found in cases of an apical hypertrophic cardiomyopathy, otherwise also associated with mid LV obstruction. And you see, this is the early systolic gradient, late systolic gradient. This is because of the two hypertrophic walls of the LV apex coming in contact and producing an hourglass like defect or so. And then then there is a gradient during diastole, and this diastole, this is because of a sudden relaxation and the pumping of the blood from the apex towards the LV cavity, or because of a delayed this. So this is known as a typical claw hand deformity. and and why again I said I've never seen such good recording which we did this time now. So this is an inverted one. If you invert it, then you get a complete picture like this. So always try to see the apex and put a pulse Doppler or so. This is just another to show this. Now coming to the main case, very peculiar title, unusual mechanism and unusual combination of two common diseases, a mystery of the missed diagnosis. Now, this was a 36-year-old female, a classical case of a mitral stenosis, who in 2003, a balloon mitral valvotomy was done in a leading cardiac center, and then she felt asymptomatically better. Again in 2010, there was a recurrence of symptoms, and in 2011, a repeat balloon mitral valvotomy was done at another leading cardiac center. Again, she felt better and then developed some symptoms in 2019 when a TDTE was performed elsewhere. That was 3D and what they reported was a severe MS of 0.8 centimeters square and severe pulmonary hypertension. And last, they wrote no other significant abnormality seen, so except for this. Then she came to us, and there was a shortness of breath, heart, then the BP maintained, there was a diastolic and a systolic murmur. We thought at that time that possibly the patient is having a concomitant mitral stenosis and regurgitation because of the systolic murmur. And then she was already in treatment, and we did the ECG echo, and it was repeated. Now, ECG, you see, there was unremarkable, except that there was LA overload, and there is a R wave is present, indicative of a right ventricular pathology and LA, and otherwise no other abnormality was seen. So when we were shocked when we started doing the echo, and the first thing we noted was there was a massive hypertrophy of the interventricular septum, and there was almost like an asymmetrical septal hypertrophy with the presence of a doming-like anterior mitral leaflet, no subaortic membrane, at least on transthoracic echo, and there was a mild MR and a turbulence here, but we were not sure whether the turbulence is contributed both by the mitral stenosis or something else also. So this was in the systolic frame to show that there was no systolic anterior motion of the mitral leaflet, but there was a marked IVS hypertrophy. Again, this is zoomed view in with anterior mitral leaflet just comes and blocks the comes into contact with the hypertrophic septum and blocks the LVOT almost in diastole when the mitral leaflet, anterior mitral leaflet hits again the interventricular septum. As you see, this is zoomed view, and you can see in between. You can see there was a mid systolic closure of the aortic leaflet, which are seen intermittently. You see here the and aortic leaflet opening, then closing, then reopening again, then closing. Of course, the mitral wall area was about 0.8 centimeter square. Now, this was a uh, this again was done. We see on in systole, in diastole, you see that there is a complete obliteration of the LVOT, and there is anterior mitral leaflet hitting against the interventricular septum. As you can see here, and at the same time, here you see a marked turbulence in the LVOT. Now, then we did this is a transesophageal echo. You see that there is no subaortic membrane. Aortic thrust are normal. And again, there is a sort of a doming and the opening of the anterior mitral leaflet coming in contact with the interventricular septum. This was another view showing the same thing, that one leaflet is immobile, other coming in contact, producing an LVOT obstruction. So if the everything was in diastole when we did a Doppler, the Doppler is in systole showing a significant LVOT gradient with the gradient of 113, and that too in the presence of a mitral stenosis, hence the gradient was could have been more. So the point that already stuck to us was that everything is happening in diastole, which is never heard of, but this is coming in systole. So what is the cause? What is being missed also? And you see the LVOT gradient. Now, so there was a diastolic obliteration of the LVOT. However, LVOT gradient was in systole, and there has to be some explanation how Hocum was missed in the three leading hospitals cardiac center will be a mystery of the century which can never be solved at how this could happen or so. So, but this was the main thing, and we could find out and we saw the literature and could not find a reason for this. The only one study we found was in from Mayo Clinic, mitral stenosis and hypertrophic obstructive cardiomyopathy, an unusual combination. They found about only 12 patients in about 22 years at Mayo Clinic, but in these cases, their mitral stenosis usually because of a of a degenerative mitral stenosis, and there they put four mechanisms of LVOT obstruction: a systolic anterior motion without severe limitation, as you see in a Hocum, but there was no sham in this case. Number two, a severe limitation of the mitral wall leaflet mobility with systolic anterior motion at the tip of the mitral leaflet and anterior leaflet, which was also not present in this case because there was no such sham. A septal encroachment towards the LVOT alone may not produce this problem, this symptom, but here The encroachment toward the LVOT was the anterior mitral leaflet and not only of the septal encroachment. So the MV displacement toward the LVOT by this. And this they have shown the various mechanisms so which none of this could be present in our case. So we went again and saw what we have missed. And if you see, a most unusual and an important mechanism for LVOT obstruction was not this. You see a hypertrophic papillary muscle. This papillary muscle comes and obstructs the LVOT, and this was one unusual mechanism. And when we went into frame by frame, and this happened, and this produces a LVOT obstruction. You see here. So rather than putting the blame on the mitral wall, you see this. And again, this is a sort of a frame. Here you see this papillary muscle and at an unusual position or project thickening produces a very narrow this LVOT, and exactly at the same place there is a significant LVOT obstruction producing a gradient. So the problem of the MS plus SCM when to suspect is you must have an awareness of this. But in these cases, everything was very evident also. Signs of mitral stenosis, LV type of apex beat, ejection systolic murmur at the left mid-sternal border, and the ECG signs of LVH. And there was no ECG signs of LVH in our case, and possibly on clinical examination we might have missed an LV type of an apex beat, and the presence of an ejection systolic murmur was always attributed to the MR. So ultimately, the management was in this case, as you see, mitral valve replacement alone may not correct outflow tract obstruction when the cause is not related to the systolic anterior motion of the leaflet. And so, what we could have done was or earlier a balloon mitral valvotomy plus a concomitant, if need be, alcohol septal ablation could have been performed because the symptoms could have been because of both of these things. But then because this lady was caught in the pandemic of the coronavirus, she wanted to go somewhere else to collect money for these two things or so. But ultimately, one fine morning, she developed an acute pulmonary edema and expired. So I think this was some of the things which we should not have missed, and this is the line of arrangement which we would have done. Thank you very much.
Thank you,
So these
sir.
are the two unusual cases which we have done.